I'm gonna wait for another minute.
Okay.
Oh my gosh, we just went to 56 participants.
So let's get this started. Good evening, everyone. And on behalf of the Resident and Fellow Education Committee, I would like to welcome you to tonight's webinar titled, How to Prepare for the General Surgery Boards. If you can just push next slide, and then next slide. So my name is, no, go back one. I'm sorry, Beverly, just one more. Yes, thank you. So my name is Maria Altieri, and I'm the chair of the Resident Fellow Education Committee, and also a minimally invasive and bariatric surgeon at the University of Pennsylvania. And I have the pleasure of co-hosting this webinar with Dr. Linda Q, who is a fellow, surgical oncology fellow at UPMC, and she'll introduce herself briefly after, right before she starts introducing the speakers. And also she's a newly appointed member of the committee as well as of today. So congratulations, Linda. And we have a fabulous lineup of speakers. So I'm very excited for this webinar. If we can get next slide. So first, a little bit of some webinar tips. Please mute your microphones if you haven't done so already. So we can just keep the background noise to a minimum. Also be mindful of background noise while you're speaking. Position your camera properly. And then limit distractions, and you can ask questions using the Q&A feature at the bottom of the screen. If you can get me next slide. A little bit about the SSAT. So the SSAT was started in the 1960s as the Association for Colon Surgery. And the mission of the society is to lead in advancing the science and practice of gastrointestinal surgery. And the vision is a global community of GI surgeons advancing research, innovation, and advocacy to benefit interdisciplinary patient care. Next slide. Regarding the SSAT membership, it's very reasonably priced, and I can highly recommend this as somebody who joined as a candidate member myself. Next slide. You can get a lot of benefits in terms of benefits. You have the journal access to the Journal of Gastrointestinal Surgery jobs, deeply discounted early bird registration to DDW, which is the meeting. Access to apply for awards, grants, scholarships, traveling fellowships, and a lot of leadership opportunities as well as networking. Next slide. And just to highlight something that is provides invaluable information for all residents and fellow, that's the Residents Corner, where we have all our past webinars, as well as surgical meeting calendars, Mentors of the Month series, a video library, and also you can follow us on Twitter as well. Next slide. And with that, I will pass this along to Dr. Linda Q for the introductions.
Thanks, Dr. Altieri. So welcome everybody. As Dr. Altieri said, I'm Linda Q. I'm one of the first-year Surgeon Fellows at the University of Pittsburgh. And thank you everyone for joining today. We hope this will be informational and helpful for all of you, whether you're taking the boards next week or looking to plan ahead. Hopefully you get something out of this. So thank you for being here tonight. Let's just jump right into it. It's my distinct pleasure to introduce our first speaker, Dr. Mary Hahn. Dr. Hahn is the Emil Holman Professor of Surgery and Chair of the Department of Surgery at Stanford University. She completed her general surgery training and a master's in public health at the University of Michigan and a minimally invasive surgical fellowship at Oregon Health and Sciences University. She's the current chair of the American Board of Surgery, secretary of the American Surgical Association, president of the Halsted Society, president-elect of the Association of VA Surgeons, first vice president for the Western Surgical Association, and treasurer for the James IV Society. She also serves on the editorial board of the Annals of Surgery and as an associate editor of the Journal of the American College of Surgeons. In recognition of her scientific leadership and contributions, she was elected to the National Academy of Medicine in 2021. So Dr. Hahn actually had a prior commitment. She was unable to join us live this evening, but she did pre-record her talk for us. So Bev is going to go ahead and play her talk. Thanks, everyone.
Hi, good evening. I'm Mary Hahn. I'm sorry I couldn't be with you in person, but it's my pleasure to talk to you on behalf of SSAT and the American Board of Surgery and help prepare you for your upcoming board exams. So my talk, I'm going to talk about the qualifying exam, the certifying exam, and then continuous certification assessment and decoding the alphabet soup of ABS certification. So first, I thought I would just review, who is the American Board of Surgery and what is our mission statement? The American Board of Surgery serves the public in the specialty of surgery by providing leadership in surgical education and practice, by promoting excellence through rigorous evaluation and examination, and by promoting the highest standards for professionalism, lifelong learning, and the continuous certification of surgeons in practice. So there's a lot to unpack there. Board certification is primarily to ensure that our surgeons in practice are professional, that they are held to the highest standards, and so that the public can understand that a certified surgeon has gone through a rigorous process in order to get that certification. So initial certification, it's a two-part step. First, you'll take the qualifying exam, which is upcoming. This is a high stakes exam. It's at a secure testing site, and it's only offered once per year. Once you successfully pass this qualifying exam, you'll be eligible to take the certifying exam. The certifying exam is also a high stakes exam, meaning you have to pass it. It's a 90-minute virtual oral exam, and we have remote proctors to ensure the security of the exam. So one thing I wanted to talk to you a little bit about today is the opportunity, and I think not a lot of our residents know about this yet, is to take the qualifying exam after the PGY 4-year. I think this is a huge opportunity for our residents to be able to take that exam, pass that exam, get that out of the way, so that month of July when they're moving to begin their new fellowship, they don't have to, in the middle of it, schedule an exam at an exam center. And the initial kind of pilot and results of a small number of residents who have chosen to take the qualifying exam after the PGY 4-year has been remarkably successful, with only one failure among all of these, the candidates who took it in the pilot. Overall, the failure rate for the qualifying exam is about 13%, 13 to 15%. Depends, first comers versus people who have taken it more than one time. So this is remarkable. The people who have chosen to take it after their PGY 4-year have actually been quite successful in passing the exam. So what do you need to do to be able to take the exam after your PGY 4-year? The program director must recommend that you can sit for your exam, and you can apply for and take the QE without meeting the required ABS case numbers. Case log meeting the ABS case numbers must be submitted at June of the chief year. To be eligible, the PGY 4 must meet all other ABS training and application requirements at the time of application to the QE, including 48 weeks of full-time clinical activity in each residency year. However, I did get some clarification from Dr. Beiske, who is the president and CEO, that the new maternity policy would also be honored here. So if a candidate took a leave for maternity and or childcare, that would not be would not prohibit them from being able to sit for the QE after their PGY 4-year. Training completed at no more than 3 residency programs and current or past certification in ACLS and ATLS. The qualifying exam after the PGY 4-year. So additional information that needs to be provided after the PGY 5-year is if the resident successfully completes a QE without having met the minimum number of cases, a case log must be submitted. Likewise, the resident completed the QE without having submitted documentation showing successful completion of FES and FLS. That information must be submitted as well before you're able to sit for your certifying exam. And upon completion of residency, the PGY4 applicants will be required to submit additional information regarding their PGY 5-year, including rotations, non-clinical time, and operative cases, as well as the program director signing off on them. So other changes to certification requirement that are new, if necessary, residents are permitted to apply for and complete both the QE and the CE prior to successful completion of the FES and FLS program. Part of the reason for this is not every program has an FES and FLS testing center. And with COVID, it's been increasingly problematic for candidates to travel to other centers to be able to undergo this certification. However, a candidate will not be considered fully certified by the APS and will not receive their certificate until proof of certification in these courses is provided. So let's talk a little bit about the certifying exam or the oral exam. I think this is the one we dread the most. So pre-pandemic, the certifying exam was an in-person exam. It was a candidate in a hotel room with 2 examiners, and they would have 3 different hotel rooms that they would run to in order to complete the exam. Each exam lasted for roughly 30 minutes per room, with a minute or 2 to run to the next room. And they were graded as pass, marginal, or fail on kind of an ordinal scale. And then since the pandemic and the inability to have in-person exams, the ABS pivoted quite early to be able to offer virtual exams. And in order to ensure a secure exam, there is a remote proctor who monitors the candidate during the exam, as well as a host who makes sure that the candidates get to the right rooms for their exam. That otherwise the exam structure is the same. It's still 3 rooms, 30 minutes per room, and is graded the same way. Overall pass rate for the certifying exam for first-time exam takers is approaching 90+%. So this has been a wildly successful pilot. So since the pandemic, when we initially pivoted to the virtual exams, it was very labor intensive because we were just learning. And however, we are able to get almost 2,300 candidates certified during that initial time in the pandemic. Required a lot of effort from proctors, hosts, as well as the examiners. This past year, we've been able to certify or administer the certifying exam to over 2,000 candidates with fewer examiners, fewer proctors, and fewer hosts. So really learning from the experience and streamlining it. So the other thing I think that's really important to point out is there have been very, very rare technical failures on either behalf of the examiner or the examinee. Having the redundancy of 2 examiners in the room, if something happens to one of the examiners, the exam can continue. And obviously, if there's an issue with connectivity from an examinee, we do try to get that person rescheduled or to make up that exam as soon as possible. So at this time, because of the success of the virtual certifying exam, our plan is for all future exams will be delivered virtually for all of our specialties for the American Board of Surgery. And this is some of the feedback that we've gotten that's helped make that decision. So from the candidates, it was much more convenient for me not to have to disrupt my practice by leaving for several days prior to the exam in preparation to take the exam. I was able to sit in my own office and take the exam, which was much more comfortable and relaxing. And there was no travel expenses. And second candidate said, I found it user-friendly, relatively low stress to use. Another candidate said the virtual experience is clearly beneficial for examinees to experience performance anxiety and exam anxiety in general, thereby aiding the examinee to find a level of comfort in his or her exam environment. And finally, not having to travel to different cities helped alleviate some of the test-based stress, as well as taking away less time from my growing practice. So as I said, all certifying exams will be delivered virtually for all specialties, and we'll continue to hone this process. We do not, however, plan to revisit the virtual qualifying exam until better technology is available to provide and monitor the exam for 1,500 plus general surgery candidates who participate each year. So many may recall in 2020, in the pandemic, we did try, based on the success of our pilot CE virtual exams, to administer a qualifying exam virtually. And it was a spectacular failure, requiring us to just stop the test, and that no candidate was able to proceed with their qualifying exam certification that year. So what happens once you get certified with your initial certification, you pass your QE, you pass your CE, then you enter into a process that we call continuous certification. And this was majorly revamped approximately 5 years ago. Prior to that, it was a 10-year high-stakes secure exam, very similar to the qualifying exam, going to a testing center, having to take a day away from your practice, answer questions that weren't really relevant to your practice. So, and what we recognize is that maintaining certification needed to be both more convenient for the diplomate, but actually more reflective of the surgeon's daily practice. It established national standards for maintaining knowledge and skill and practice. We felt like a 10-year exam did not do that. Documents the ongoing commitment of surgeons to professionalism, lifelong learning, and quality patient care. And it upholds the board certification as a standard of quality as defined by the surgical community, and gives the surgical community a proactive position in healthcare quality debate using surgeon developed metrics and reporting methods. So the continuous certification assessment was designed really to address the diplomate concerns regarding the traditional exam. So 58% of our diplomates wanted a more frequent open book exam that was lower stakes than the 10-year high stakes model. 67% would like to complete the assessment no more frequently than 2 years. And we're strongly in favor of being tested on both core surgical concepts and practice-specific concepts. So each ABS specialty board determines the contents for their specialty with input from diplomates and societies. The CCA exam is 40 questions presented in random order. So 20 core, 20 a topic that you could pick if you're a trauma surgeon or a GI surgeon per se. Content focuses on very contemporary important changes in surgical practice. And the topic areas evolve based on changes in the field. Questions are written by community, including rural as well as academic surgeons. So the assessment happens, it's an on-timed open book exam, and it provides immediate feedback to the learner. You take it on your own computer. There is a reference list provided by the American Board of Surgery of what topics are going to be on the exam, as well as the references or the papers to support those topics. And you're given 2 chances to answer a question correctly. And you immediately know whether you passed or not. So the way that this exam is delivered, you do have to get 80% or 32 of the 40 questions correct after 2 attempts. However, you have to get 40% of the questions right the first time. If you just blow through the exam and you get less than 40% correct, you fail. If you get more than 40% correct, then you go back and you revisit the questions you didn't get correct. You must pass an assessment every other year. And you're given, once you start the exam, you have a window to do this exam. It's like a 6 to 8 week window in the fall. But the day you start your exam, you have 2 weeks to finish your exam or get through the 40 questions. So you could do 10 questions and then say, okay, I'm gonna take a break and come back and finish this exam later. Those questions are saved. And then if you say fail that exam, you can retake the assessment the following year rather than 2 years. So within that kind of 2-year period, you can retake the exam the following year. However, if you fail it twice, if you're not able to pass this exam, then you must pass a secure exam similar to the qualifying exam in order to maintain your certification. So CME and self-assessment are other requirements that are necessary to maintain your continuous certification. You have to have a full and unrestricted medical license. You have to have hospital privileges. You have to have 2 references submitted every 5 years, participate in a practice improvement program. You submit an operative log every 10 years, and there's an annual fee for your continuous certification. Some of this will be changing because there's some requirements coming down from the American Board of Medical Specialties, to which the ABS belongs to, but for right now, these are our requirements. The diplomats are highly satisfied with the CCA. If you can ask people, how they really feel about being tested, most of us would not want to be tested. So we feel that, approaching 80%, feeling that it was fair, it was relevant to practice, it was a valuable use of time. They would recommend it to a colleague. More importantly, what we were really heartened by is that the diplomats felt it was timely for their practice, that it was important for their practice, and it will improve how they practice. Like, that's a pretty high bar. And the fact that for the majority of our specialists, 80% felt that we achieved that bar was pretty remarkable. And the other thing they noted is they did not have to take time away from their practice in order to participate in the assessment. So I am thrilled that you are logging in, getting prepared for your upcoming exams. I wish you the best of luck, and we look forward to welcome you as a diplomate. Thank you again.
Okay, thank you to Dr. Hahn. I know we all wish her well in her term as chair for the next year. And we do apologize for some of the technical difficulties. I think it was a little bit blurry on my screen as well, but as Dr. Altieri mentioned, we'll have the slides up on the website after the webinar. So we'll just keep going. Our next speaker, it's my privilege to introduce Dr. Jim Lau. Dr. Lau is a professor of surgery, vice chair of education, and the division director of minimally invasive and bariatric surgery at Loyola University Medical Center. He completed his general surgery residency at the Indiana University School of Medicine after 2 active duty years in the US Air Force as a flight surgeon, followed by fellowship training in minimally invasive bariatric and robotic surgery at Stanford. He received his master's in health professions education from the University of Illinois, Chicago. He is currently the chair of the clerkship committee of the Association of Surgical Education, a co-chair for the curriculum committee of the ACS, Accredited Education Institutes Consortium, and an associate member of the American College of Surgeons Academy of Master Surgeon Educators. Dr. Lau, please take it away.
Great. I hope I'm not on mute.
You're not.
All right, and my slides are not blurry.
They are not. If
Okay,
you can make
great.
them full screen though, that'd be great.
I thought I did. Let's see if I can do this again. Better?
Yes, perfect.
Okay, perfect. Well, thank you to Dr. Altieri and Dr. Q for inviting me to do this. I think most people who know me know that I almost never say no, because I always think of myself as a resident. So I approach this topic kind of from the perspective of a resident or a fellow who is aiming to take this qualifying exam. So I was told to go ahead and talk a little bit about the nuts and bolts, and this may overlap a little bit with Dr. Hahn's talk, but not too much, and then how to prepare a kind of a brief kind of suggestion on how to prepare for the QE. So when we talk about the nuts and bolts, the ABS general surgery exam, and we're talking specifically about the qualifying exam, you have 7 years to achieve overall certification for the American Board of Surgery. You have 4 chances for the qualifying exam and 3 chances for the certifying exam. So if my addition is correct, that means 7 years. to achieve overall certification. So if it takes you 2 or 3 chances for the qualifying exam and 1 or 2 chances to successfully navigate the certifying exam, and you're within that 7 years, you can still achieve American Board of Surgery status. You have 1 shot each year, and you should apply at your PGY 4 year, now that it's no longer a pilot, or after completion of your residency, to ensure the maximum opportunities. So you have 1 shot per year. So if you wait to take your certifying exam 2 years after you graduate, then you've lost 2 chances for the qualifying exam, and that's how that works. Usually the test is in July prior to the fellowship starting, now all in August 1st or around August 1st. So the bottom line is register and take the qualifying exam as soon as you can. If you want to do it during your 4th year, people still are doing it after residency before their fellowship, but you should register and take it at the first opportunity that you can. A word about the Q exam day. As you heard Dr. Hans,
could you say that?
You heard Dr. Hans say that they no longer are doing it virtually. So the QE exam day is back to the traditional format of an 8-hour computerized multiple choice exam. They are taken at an authorized testing center only. So you must register and then go and empty your pockets and those kinds of things. The qualifying exam is taken in 4 sections, each about an hour and 55 minutes apiece. You have an optional 10-minute break between the first and second section. You have an optional 40-minute break between your second and third section, and then you have an optional 10-minute break after your third section and into your 4th section. And you don't have to take those, but those are kind of built in place if you need those breaks. The qualifying exam is 300 questions, 75 questions each section. And then once you finish 1 section, you can't go back to the previous section. So if you're in section 2, you cannot go back and answer section 1 questions. There's a scale, the scores are scaled by percent correct to a score of 1 to 900, and then passing is 400. None of the things that I've gone over in the last 2 slides are super secret information. All this stuff is on the American Board of Surgery website and is easy for people to look for. When we always ask how many attempts are needed to achieve General Surgery Board certification, one of my colleagues, Dr. George from the University of Michigan, and his colleagues went ahead and tried to answer this question. They looked at about 15,000 surgeons' attempts to achieve board certification between 2000 and 2013. And the bottom line that they were able to find was, of those who obtained board certification, 97% passed the QE in the first 2 attempts, and 97% of those who took the CE passed it in 2 attempts. So if you looked at those who failed more than twice on either the QE or the CE, 67% of those people eventually achieved board certification. If you look at the QE content, this is also on the website, 80% is in patient care. And if you looked at the different subject areas, they're mostly in abdomen, alimentary tract, in surgical critical care, and in trauma and vascular. So these are the subjects that are covered by the qualifying exam. 20% are in medical knowledge, which encompasses applied science, preoperative evaluation, and perioperative care. And then there's a small section which is miscellaneous topics, usually ethical. In suggesting how to study, if you ask any person who is in surgical education, they usually say that if you want to do well on the qualifying exam, that you should study and come up with a study plan for your yearly AB sites. And so I wanted to find out why everybody always said that, including myself. And if you look at Joe Bieski's and Dr. Malangoni's and Dr. Lewis's evaluation of their program, of the ABSITE training and whether it predicts certification in the QE or the CE. What you see is that the ABSITE is more predictive of passing the qualifying exam and not the certifying exam. That if you look at different PGY levels, if a PGY 5 takes the ABSITE and does well, that their good performance predicts passing the qualifying exam. The opposite does not hold true. So if you do poorly as a PGY 5 on the ABSITE that particular year, it does not predict that you do not pass the qualifying exam. And there has been nothing to show that the ABSITE predicts any kind of performance on the certifying exam or the oral boards format. So because of that, the most common thing that people say answer to how you should study for the qualifying exam is to prepare for throughout the year and take the ABSITE exam to examine the areas that you did not do so well on and to study for those on the subsequent years and do well on your ABSITE the 5th year. If you look at the ABSITE category weights, the patient care is 72%, the QE patient care is 80%. The ABSITE's medical knowledge percentile of questions is 24%, where the medical knowledge is 20% on the QE. So as you can see, there is a correlation of the subject areas that's covered on the ABSITE and it correlates over to the QE. So one can see that if you study for the ABSITE and on a yearly basis, that is one of the best ways to prepare for the QE. If we look at program factors that influence the American Board of Surgery in training exam or the ABSITE, there's lots of different educators here at different institutions that took also was in on this study. And you looked at the different ways that people, that program directors talked about that influence the scores of their residents taking the ABSITE. If a resident tracked the reading throughout the year and not just crammed at the end of the year, they did better on the ABSITE. And then a remediation program that was mandated for residents that didn't necessarily perform well helped those residents perform well on subsequent ABSITEs. What did not influence scores were number of education hours per week on a formal education program, nor the frequency of ABSITE review sessions within formal education time during residency programs. So the key is to do some kind of study or tracked reading throughout the year and not at the end. This particular study was a single institution qualitative study, which asked their residents for this particular program, which were the study techniques, and then that they utilized for the ABSITE, and then they correlated to how well they did on the exam. The high utility study strategies were spacing, which is basically implementing a scheduled practice throughout the year, and then testing, which is self-testing or taking practice test questions of the material. But the key to these high utility study strategies were that they have to be throughout time and not toward the end. The same study asked their residents how long they took to study. If they were throughout the year, those 8 residents or 35% of the residents of this program took 2 hours a week to study throughout the year. Those who crammed, which 87% of those in the residency program, they took 420 minutes a week to study prior to the ABSITE. And the type of resources used when studying a topic that they were learning for the first time were textbooks first, then review books, and then question banks. There's tons of resources out there for studying for the ABSITE or the qualifying exam. The traditional textbooks are Schwartz, Sabiston, Greenfield, and there's a whole host of others. There are board review books by DiVirgilio, Dimick, and Scher, and there's a lot more out there too. There is a system of pre-recorded lectures as well as a question bank and called the Pass Machine. And then most residents have score provided to them by their programs or their residency programs, and that is a tremendous resource. TrueLearn is a question bank. And then CSAP is a program that you can pay for the American College of Surgeons that is a testing bank. And then the ACS Comprehensive General Surgery online review course is similar to the PASS machine, but has less resources available to it. And if we look at the assessment of general surgery resident study habits, and this is basically to answer the question, do question banks help? And it depends on your preferred method of study and whether you do respond or not. But on this particular study, what it showed is that if people utilize test banks, the more questions they utilize, the better they did on the app site. If in this particular study, the residents used all 1,000 questions in the TrueLearn data bank, that the overall percent correct increase by these on an average by the residents was 3%, and the increase in percentile rank was by 20% if you used all the questions in the question bank. So I shamelessly took these screenshots from one of my residents here, Giacomo Waller, who is our administrative chief resident in charge of education. And what I wanted to do is to highlight how you can create a study plan for your AB site, which can help you for the qualifying exam. If you go on Google and you type in surgical core, then you could find the SCORE General Surgery Resident Curriculum portal. Or you can just put it as a bookmark. Sign into your SCORE portal, which your residency program likely has purchased the subscription for you. And then where it says assignments, go ahead and click assignment, create an AB site study plan. And then you should put a due date for you so that it can program a plan for you throughout time. And then find your AB site sheet and put in here the areas where you did incorrect answers or areas that you think you need to study. Select those areas for study and then create your AB site study plan with a due date and then click through them throughout time. So take home points to studying and preparing for the AB site is that if you prepare and study for the AB site over time, that this prepares you for the American Board of Surgery qualifying exam. Tracked reading throughout the year helps improve the scores for the AB site. So not just cramming, but a reading plan or a testing plan throughout the year helps best. The spacing is a technique that does spaces throughout time. Self-testing with question banks can help. And remediation programs, which have shown to help, are just monitored and tracked reading and question bank programs. So thank you for the opportunity to talk about the qualifying exam for you all in the SSAT. Thanks.
Thank you so much, Dr. Lau. I would echo the comments about using SCORE to prepare. I know that I personally thought it was a little bit clunky of a system to get used to, but actually a lot of fellowships use it as well. My fellowship in Surgeon definitely uses it as a resource, and our boards are based off of it as well. So I definitely echo the utility of that. And I think we'll go ahead and save any questions that anyone has for our Q&A session at the end. So keep them in mind, or you can type them over to me and I'm happy to ask them for you if you want. But we'll move on in our agenda, and I have the pleasure of introducing our next speaker, Dr. Timothy Vreeland. Dr. Vreeland is a surgical oncologist and hepatobiliary surgeon at Brick Army Medical Center in San Antonio, Texas, where he also serves as the associate program director for the general surgery residency program. He is an assistant professor of surgery at the Uniformed Services Health Sciences University and an adjunct assistant professor of surgical oncology at the University of Texas MD Anderson Cancer Center. His research focuses include novel applications of immunotherapy for cancer, improving outcomes for patients with hepatobiliary malignancies, as well as using novel media to improve surgical education. His clinical interests include minimally invasive surgery for cancers of the foregut, liver, and pancreas. Dr. Vreeland, thank you for being here with us tonight, and we look forward to hearing from you. You're muted, sorry.
So no, you can't hear me okay. Is that better? All right, good. All right, slides look okay?
Yes.
All right, cool. All right, so you guys have had a couple nice talks already. I'm going to just kind of go through my thoughts about the certifying exam, which is a very different beast than the qualifying exam. So a couple disclosures. I work with Behind the Knife. They do have a series for the qualifying exam, which I will not endorse, but it is out there. I also work with a company called Online MedEd, but that's more med student education, not really relevant. And then I do examination for caliber boards, which is one of many options for doing practice for the qualifying exam. So I am a paid consultant for these companies, so I just want to fully disclose that before I get started. So my unpopular opinion is that the best way to prepare for this test is to read for 6 or 7 years throughout your residency. So I know that's not what you want to hear today, but I think if you're well prepared throughout your residency, the oral boards really are not super difficult. Obviously, there's a lot of anxiety associated with this test, but if there are any junior residents on here, I think getting started, as you heard in the last talk, and reading all the time throughout your residency is really the best way to prepare for these tests, and you will be well prepared if you do that. But I will go through kind of, while I won't encourage cramming, how I think cramming is done well for this test. So just some general facts. You've kind of already heard some of this, but you have 3 30-minute quote unquote rooms. They used to be real rooms, and now they're virtual rooms, 2 examiners in each room. Each one has 4 scenarios. Often there's a theme to the room. So usually like the one room is trauma plus something, so you get 2 trauma scenarios in that one room. And so just to kind of understand how that's going to go, the 2 examiners alternate, and then the one who's not actually giving you the scenario sort of stares at you awkwardly the whole time. So that's enjoyable. But just so the more you practice, I think kind of getting used to that, the more on the day of it won't bother you. And then you get a score for each scenario, kind of a composite score for the room, and then you get a composite score for the whole thing, which is basically just pass fail. The key to keep in mind, and I really try to harp on this with my residents, is you can fail a scenario and still pass the room, and you can fail a room and still pass the test. So I think one of the mistakes that people make, and one of the reasons people fail this test, is that they have a bad first room or a bad first scenario within a room, and then they're so caught up on that they can't think about the other scenarios. So it's really important, each scenario takes about 7 or 8 minutes. It's very important that when that scenario is over, you fully mentally move on from it and do not think about it anymore. Don't try to go back in your head and fix a mistake you made or anything like that. Just move on. It's okay to fail a scenario. Move on to the next 3 in that room and do well on them, and you'll be fine. And same thing, if you fail a room, you can still pass the test as long as you do well in the other rooms. So you really have to be able to put things behind you in this very short test. Again, it's 90 minutes. It feels like it goes by in 5 minutes. So you just have to stay very, very much in the moment when you're taking this test and not harp on any mistakes you previously made. It is not the ABSITE, so it's very different than the QE. So you have to study for it differently. We'll talk a little bit about that, but it's not a fact-based, study in a lot of ways. I mean, there are some moments in this exam where they may ask you some kind of factual questions, and if you get those right, that sort of builds up your quality of that answer in the examiner's head. But this is not a series of fact-based questions. You got to kind of play the game, and the best advice I think I've heard on this is treat it like a conversation in the surgeon's lounge, like somebody's coming to you and presenting a case and they want your thoughts on it. And that really is kind of the best way to think of it, is just that you're having a conversation about a series of patients, and you're going to give your best thoughts on how to manage that patient. And in some ways do what you would do in real life, and other times you have to kind of not do that. So you just have to understand that this is the test, not necessarily you trying to be absolutely 100% right. I think some people who know a little too much on certain questions may get in trouble because they know the latest and greatest thing on breast cancer, and the person asking them the question just wants the textbook answer, and you can get a little bit lost. And if you don't have that perfectly down, you can kind of drive yourself into a bad place. To that end, when you don't have it nailed down, keep it vague. So one of the mistakes I see people do a lot is they try to name a trial. I like to ask oncology questions. I'm a surgical oncologist. So, when you're trying to talk about Z11, but you don't really know the details of Z11. So it's okay to just say I know there's randomized data that supports not doing an axillary dissection after a positive sentinel node or something like that, rather than saying, well, based on Z11, and then they're like, well, tell me some details of the Z11 trial. And you don't actually know those details. You just set yourself up for failure. So if you have it nailed down and you want to get those bonus points in the examiner's head, go for it. If you don't, then keep it vague. Don't pigeonhole yourself and end up hurting yourself. So we'll kind of go over my how-to to get ready for this test. So we're going to make a plan. I think that's key. Same with the qualifying exam as well. Start comprehensive, do test-specific practice, and then figure out where you're weak and focus there. So we'll go through kind of each of these. So starting with making a plan, I think, personally, I like Google Calendar, whatever calendar you use, lay out a realistic plan of how you're going to cover everything. And I would say cover everything twice. So when I studied for this test, I took 1 week off before the test, and I took 6 weeks to study for it. So I slowly went through everything one time over about 4 weeks. And then I went through everything again over about 10 days. The first week I kind of did half days. And then that second week when I was off, I dedicated the whole day to it. And then the last few days were just for kind of going over the areas where I was weak or concerned, or, some people use those last few days to go to a review course, which I think is fine too. But, whatever time frame you're going to allot for yourself, set out the calendar, set which topics you're going to cover which days, be realistic about it, leave gaps for time off, or if you need to catch up, you may get busy one day and not be able to catch that day. So you got to leave, your Saturdays off or whatever, so you have time to catch up. But be realistic, set a calendar, and then stick to it. So don't get caught in a rabbit hole studying way too much on your first topic and then you're 3 days behind already. And I think that no rabbit holes thing is very key for this exam. You don't have to know every little detail of everything. And sometimes when I was studying for the ABSITE or for the qualifying exam, I spent too much time studying extreme details so that I would know that one question that I knew was coming about the trivia of this or that. You really don't need that stuff for this exam. You just need to pass every topic. And so don't get caught in rabbit holes. Don't try to memorize every detail. Don't try to memorize staging of cancer. Just know the basics enough to pass. And that's really the way to go. So again, start comprehensive. How do you do that? So I think you use either a review text or some source that's going to be very comprehensive. So, the list of sources I would recommend, there is the ABS list. So I just took a snapshot from the ABS website. I didn't find this to be super helpful because it's so vague, like general abdomen. What does that really mean? What I think you really need is a source that actually goes through, previous topics that have been asked, or, talk to people in your program about what the most common questions are and things like that, and make sure you nail down those. So again, Behind the Knife has all these podcasts on every topic, and then now they have a board review. Again, I was paid to help develop that, so I don't want to be too strong in my recommendation, but they have a lot of free resources through their podcast, and I think it's great to use that, mainly because it's going to be comprehensive. You're going to kind of cover everything. So a lot of our residents kind of study a topic, and then during the course of that day, they listen to the podcast on that topic when they're driving or working out, and it just kind of gives you some comprehensive ability to cover a topic. I really like this book. I received no money from this book, but I thought this book was great because it gives you a broad kind of comprehensive review of all the different topics that might be asked, and then it kind of helps you work through how a scenario might present on that topic. So I use this book as my backbone, but there's obviously lots of books on the topic. And just make sure you use something that kind of covers all the different topics you might come across, and then lay out how you're going to get through all of those. And then obviously there are courses on this, like the OSER course, and they will give you resources that have kind of a broad outline of what you might be asked. So, I think pick a source. It doesn't matter, but pick a source that's going to cover comprehensively all the possible scenarios that you might come across, and then lay out a schedule where you're going to go through all of those. I would say twice, at least once. And then make sure you go within that topic and nail down the common scenarios. So like for me, I thought vascular was probably my weakest topic. So what I did was I had carotid and like, SFA bypass nailed down because I knew those were like the two most common vascular things that were going to be asked. And then I had a pretty good idea on like aorta and a couple other topics that were in the books that I figured might be asked. And then I sort of ignored the rest. And I said, listen, if I get a scenario that's way out in left field from vascular, it's just going to be the one that I fail and it'll be okay because I'll pass everything else. But I think if you try to know absolutely every scenario in the topics where you already know you're weak, you're just going to run out of time. And so I think when in the areas where you know you're weak, really go to the common questions and try to just memorize the right answers for those, because it kind of depends. But if you're 2 weeks before the test and you're like trying to learn every topic of vascular and you didn't vascular is your weak topic, you're just not going to do well on it. So really focus on the common topics in your weak areas. And then again, less facts and trivia, more algorithms and scripts. So for me, what I did was I actually hand wrote out the algorithms for the different common scenarios I thought I was going to come across, and then wrote out a script where I would write like, I think they're going to ask this question. Here's roughly how I'm going to answer it. Just kind of short little answers, and then kind of went through and had a basic script for most of the common scenarios. And I think that was a good way to study because that's really how the test is done. And some of the board review materials will help you with that script. That blue book that I referenced, this one is kind of built like that. It's really a conversational script more than anything else. All right. And then test specific practice. So I think, the only way to practice for this test is either you mentally doing the reps of kind of going over your script in your head, or doing practice scenarios with someone. So, either find somebody in your program. And I would actually suggest that you do it over Zoom rather than in person, because that's how the test is now. So, like in our program, we do it over Zoom with attendings and residents, and we allow the other residents kind of watch while one resident does it, but we do it over Zoom now because it's just easier. Or I'm sorry, it's not easier. It's just more like the real test. And then, you may have regional mock orals through your program, stuff like that. So the more reps you can get, because it is a weird thing. It's just different than really, any other test you've ever taken. It's just weird. So the more reps you can get, the better. And then there are all sorts of different courses, websites and apps now where you can do practice scenarios. So, you go find those on the web, and a lot of them you have to pay for. But I think if you're struggling, it's a really good way to kind of get some feedback. And then there is the ACS comprehensive review course where they do some Zoom exams as well. That's just another possibility. And then through those, what you really need to focus on is figure out where you're weak, right? So you got to go chase that feedback. You got to do scenarios with people, ask for the feedback on, where are you weak, which topics are you weak on? And then, are you doing something weird with your body language, or doing something, where you're kind of taking really long pauses? That's one thing I've seen that I think people lose points on. And when I say points, I don't actually mean points, but the examiners sort of get frustrated with how long your pauses are, or if you're asking too many questions and kind of giving these short little answers rather than giving kind of nice long summaries. They're just little stylistic points that your attending should be able to pick out, or somebody even, a couple of years ahead, even residency, who just took the test, go seek that feedback. Again, it's easy to do over Zoom now. And I think you should that's really important, is this kind of specific practice for the test. And then, once you know you're weak, note your weaknesses, focus. Then once you know you're weak, focus on those common scenarios within these weak areas. I really think that is an important thing, because again, you're going to get you're going to get a breast question. So if you're terrible at breast, just figure out what the most couple common scenarios within breast are and kind of nail those. You're going to get a hernia question. So make sure you kind of have those nailed down. Like a lot of people get a question on men's syndrome. So just nail down those. Carotid, know how to talk through the steps of a carotid, even if you've never done one before, and really focus on those common scenarios in the weak areas. And then again, your goal is to pass each area. Not, it's not like the ABSITE where if you get a 90%, you get an attaboy from everyone, or pat on the back. Nobody cares. All you have to do is pass. So your goal is to just pass each area, be able to give a passable, reasonable answer to every common scenario, and you'll pass the test. You don't have to nail everything. You don't have to go down in the rabbit holes of every breast cancer trial that's ever been done and all these different things. You really should kind of focus on being able to give a safe and reasonable answer for every scenario. again, don't chase the rare topics. I really think this is a mistake that I made when I was studying, and most people do, is they waste time kind of going down these rabbit holes. Just be able to give a reasonable passing answer to every common scenario. So this is just one kind of, I don't know, I didn't do a review course. I know a lot of people do. I think they can be helpful if it's good for you, but I do think that now there are so many resources available without having to travel for a course or even doing an online specific course. But there is the one study on this topic was done in 2015 and basically showed that doing a review course did not actually provide an advantage for passing the test. So I think if you go into the review course ready to pass, you're going to gain confidence from it. If you go in and you are relying solely on that course to provide you enough to pass, you're going to lose confidence. And so much of this test is confidence that it may actually hurt you. So, I'm not sure what to say about that as a bottom line. I didn't do a course, so I can't really speak to it, but don't feel like you have to. Don't feel like you have to pay a bunch of money to do a course. So that's all I have. I'm happy to answer questions. My email's there, my Twitter handle. So, if y'all have any questions or concerns, feel free to ask or do it in the Q&A here.
Thanks so much, Dr. Verlin, for all of your insight. I completely agree, and I'm glad you talked about asking other people to practice with you. If you're in fellowship programs, if you have second year or third year co-fellows, I found that those are really good people to ask because they have just taken the course and or the exam, and they had a lot of data and a lot of practice questions, and they can review it with you. So thank you so much. We will, the other thing I was going to say is at least this past year, the CE was offered twice in the fall and in the spring. So I can't speak to people who go directly into practice, but if you are in a fellowship program, you can kind of time it based on your rotations. If you're on a little bit of a lighter rotation, you have a little bit more time to study. That can be helpful as well, just in terms of planning out your year. So I'm going to go ahead and introduce our last speaker, Dr. Faven Babu. So Dr. Babu was somebody who was listening to these talks last year, and now he's on the other side, and he's going to give us his insight. He graduated medical school from the University of Illinois College of Medicine at Chicago and completed his general surgery residency at Loyola University Medical Center. During residency, he completed the T32 NIH Physician Scientist Training Program at Loyola's Burn Shock Trauma Research Institute and earned a master's degree in clinical research methods. In 2021, he started his fellowship in cardiothoracic surgery at the University of Chicago with plans on entering the field of thoracic surgery. His clinical interests include thoracic oncology and benign foregut. Dr. Babu.
Thank you, Linda. Just gonna pull up my slides here. I'm going to stop my video just because my internet connection isn't the best here. Welcome, everybody. I appreciate you taking the time for this webinar. So my talk is kind of like the perspective of the examinee after the exam and successful. So I did pass the board exam. Disclosures, I do not have any disclosures. And a little bit about my background. Linda covered most of this, but I did most of my training, or all of my training in Chicago medical school and then general surgery residency at Loyola. Spent 2 years in the lab, got a master's degree at the time, and then I was applying into cardiothoracic surgery, and I'm at the University of Chicago with plans of entering general thoracic once I graduate. So during residency, I think this is kind of a broad overview of what our department specifically provided. So we did undergo mock oral exams. These were both split between senior and junior. They occurred about once a year, and they were very much like the actual exam before it was virtual. So we dressed up in suits. We had 2 examinees per room. Everything was very professional, and then we got our scores back and feedback only after things were done. And as chiefs, we got a chance to both participate in mock orals and as well as give them to the junior residents. So it was kind of good to see scenarios from the examiner's side. During our my PGY4 and PGY5 year, our department started doing monthly mock orals for the more senior residents. This happened about once or twice a month, and it was with the PGY4 and 5 class. One person was in the hot seat, and we'd go over 2 or 3 scenarios with real-time feedback. And then throughout residency, PGY 1 through 5, our weekly M&M sessions were pretty good practice, I think, in retrospect for the mock orals. At least in the first 3 years of my residency, clinical years, this was very bare bones. So we would go up, present a patient, maybe show a CT scan, no PowerPoint slides, no lit review, and then we would just kind of get grilled by all the attendings in the department about our clinical decision-making, differential diagnosis, operative plans, what we could do different. So while it was terrifying at the time, I think it really did help me think on my feet more often and be used to, answering under pressure. So how I personally prepared, in addition to using the CSAP question bank for the QE, which I thought was helpful, my old app site notes, I feel like a lot of studying for this exam specifically happens when you study for the qualifying exam in the summer. You're going over all the topics, all your old notes. So kind of like the medical knowledge portion of it is pretty much built during that time you're studying for the qualifying exam. I used the Osler course. I bought the fall 2021 version. It has tons of videos on many hours of pre-recorded virtual sessions, which I found very helpful. You do get included mock oral sessions, 2 free sessions, I believe it was, during the actual program. I didn't actually utilize any of those. I thought it was worth the money. It is pretty expensive, but what I think is important is it gives you access to hundreds of common scenarios. So I found it very high yield in order to get my differentials going for each of the specific sections. And then you can always pause the videos and kind of play along and see how you would answer and how the examinee would answer. So depending on most of the scenarios, I felt were very high yield, especially for colorectal, breast, and vascular. So my personal experience with the certifying exam. So I took mine on Zoom. I did have a technical issue. There's a security double feature where you have to have a camera recording you while you do the exam. For whatever reason, my camera, they weren't able to see, but the exam just proceeded on. I was stressed out about it at first, but they said, forget about it, we'll just go ahead. I thought the proctors that I had virtually were very good. Everything was on time. I was put in the right session at the right time. There wasn't any downtime in between the sessions, so no bathroom breaks. And there weren't any technical issues in terms of my examiners and their mics or being able to see what they wanted me to see or anything like that. I do personally think that taking the exam over Zoom is a big advantage for the examinee. I personally found it much less stressful. I mean, I was able to take the exam in my apartment with no distractions. It's where I studied. It was kind of home-based advantage, I feel. And also, it kind of made the exam less intimidating and less personal. So the strategy I employed is that I kind of minimized my Zoom screen. So it wasn't like 2 faces were staring at me. I just kind of did it over audio and stared directly into my laptop camera the whole time. Because you have to have your hands in front of you and be on video all the time, it kind of takes out any room for fidgeting. So it's kind of, I think, a lot of the intimidation factor in the exam is minimized by doing it via Zoom. And, this is just my personal take on it, nonverbal cues. So the examiner who's not examining you, so one person's giving the prompt, one other person's in the room, isn't isn't talking to you directly, but as we all know, it's hard to maintain focus on Zoom. So it's not like they're just staring at you the whole time you're talking. What I found is that you can actually pick up some subtle nonverbal cues from them during the exam. I remember one of my examiners was like literally nodding while I was giving my responses. So I would not bank on this, but I think that's just one added thing that I found was actually helpful during the exam, is that you're not having another person just staring at you while you're under stress. In terms of how I felt the examiners were, I kind of split it up in my personal experience with 3 types of examiner. So there's a classic one, which I think most of you will encounter. And this is a scenario you're going to be most familiar with. So they'll give you a history of physicals, some pertinent labs in the clinical scenario, and they'll ask you to take over workup for the patient from there and ask you what your plan is. The scenario usually goes over a course of a day or a couple of days in the hospital. And they basically want you to walk through what your diagnosis is, what your management is, are you taking them to the operating room? And then they want to know what your operative plan is, and we'll ask you to describe a surgery. So this is something, especially if you do the Osler course or any mock orals with other people, this is what to pretty much expect, I would say, on the vast majority of your scenarios. Then there was an examiner, which I think 1 or 2 scenarios was a straight to the point person. So this person gave a very brief history, gave minimal information. It just says, patient arrives in your clinic, had a biopsy, shows this, what are you going to do? And then you would start to, recount and go through. And as soon as you said the right thing, they're like, okay, you do this, now you do this. So this type of examiner actually advanced the scenario really quickly on my behalf, and then had points where they wanted to stop and ask me questions. And I felt like this examiner was much more interested in my decision making rather than kind of my workup. So they would ask me to defend my reasoning for why I chose to do one thing over the other, why I chose one imaging study over the other, and why I would elect to treat something with chemotherapy and versus going straight to the OR. And then I had one examiner that had basically what I call a choose your own adventure. This is where you get a very simple scenario. It's typically, in my experience, this was all in the abdomen, something you're like, they're not actually going to test me on this, right? It was something either like a diverticulitis, appendicitis, or cholelithiasis, and the prompt will be so straightforward that you end up in the operating room, but then they'll switch up what you find. And what I kind of like these scenarios because they switch it up and ask you to say, you find this instead. What are you thinking? What are you going to do? Okay, but instead you find this. How is that going to change your management? Would you still resect it if you found this? And these were kind of like quick hit points. And I actually had one scenario where they asked me 6 different variations of what I saw in the right lower quadrant. So this scenario was much more, I felt, on your surgical decision making rather than, getting the nuts and bolts and saying, I want to make sure I have this lab, this imaging study, and all of that. There was a lot of intraoperative decision making, and I felt like it tested a lot of areas at one time. So overall, I felt the scenarios were extremely fair and straightforward. After taking the AppSite for 7 times, I was refreshed to take a straightforward test and something that showed exactly what I prepared for. I was lucky that I have encountered every single scenario that I got asked on during my clinical training, and the Osler course covered all but one of the scenarios almost verbatim. So I felt I had the good resources both in my personal experience as well as from my review course that helped me with the test. At no point did I feel like the instructors were trying to trick me or mislead me. In one situation, I actually had to have the instructor repeat what they said because they said something in error, and there was no animosity or anything. They apologized and just restarted the scenario at the correct point. And I think overall with the scenarios, above all else, be a safe surgeon. We say that all the time during training to each other. You might not know how to do every operation. You might not have encountered everything that you get asked on boards, but you know how to be safe and you know how to live to fight another day. We've all been in scenarios where you have to bail out of the abdomen pack and go. And sometimes if you find yourself in a scenario clinically, you have to think about, and you don't know the right answer, you just have to think about what can I do that's safe? What can I do that's not irreversible? And what can I do to say that, I didn't encounter this situation, but I know what I shouldn't do. And I know what is safe and how I can keep the patient going for further care. Endoscopy, be sure you know endoscopy as if it is a clinical scenario. So you have to be able to describe an endoscopy like a colonoscopy or an EGD the same way you would describe where you would place reports for an appy, what stapler you would use. This includes patient positioning, conscious sedation. I was actually surprised because one of my scenarios was kind of working towards an esophageal motility disorder, and they asked me to describe the EGD, not a surgical approach that I would use. So make sure you know endoscopy as if it's another surgical procedure you do all the time. And then you will get a critical care scenario. And my personal take on this is that the critical care scenario is a puzzle you cannot solve, and accept that. And don't get thrown off about that. It's not about having the diagnosis. It's about showing how you can continually reevaluate the patient and what tools you have in your armamentarium in order to keep them stable and keep them safe, and in order to basically address each issue that comes about. So, and in this scenario, don't forget to state obvious things. This is where these are things you would do obviously clinically, but you might not voice out loud, like putting the patient on telemetry, moving them over to the ICU, making sure you redraw labs, that they have IV access or central access. And I feel like this scenario, at least what I've seen through the Osler course and as well as what I experience, is the scenario really doesn't stop until you run out of things you can do or your patient ends up on ECMO. So you kind of sometimes in these scenarios really have to exhaust the critical care knowledge and throw the kitchen sink at the patient to make sure that everything is covered and that you keep progressing your knowledge. So at this point, it's been 90 minutes of your exam. There aren't any really breaks. You've lost all track of time. And honestly, at this point, this is how I thought I was going to end my exam. But luckily, being that it was straightforward and I felt that I had good preparation from the course, this is how I actually felt. I don't say this to brag, but I say this because I really do feel that the test was fair. They didn't ask me anything unexpected and they weren't trying to trick me. So because I was able to rely on my clinical knowledge and what I studied on, I knew I didn't do anything horrendous or damaging to the patient. And I knew at the very least I was safe on all my answers. However, we're all overthinkers. This will get the best of you. It's the next day when you're like, wait, did I say that? Did I restage the patient after chemo? Did I make sure I got the preoperative workup correctly? Did I say this? Did I do that? Did I say which suture? You're going to have a million of these thoughts after the exam. And you just got to try your best to shake that and move forward. The exam is over, you've taken it, and you just got to wait for the website to tell you if you passed or not. So hindsight's always 20/20. So what would I have done differently? I thought the Oslo course was good, but there was a lot of features in it, which one included a stepwise study plan, but also those virtual mock oral sessions that kind of have to be scheduled in advance. I'll talk a bit about why I didn't do those, but they are included and you paid for them and you should use them. In addition, you can also buy extra one-on-one sessions in the course if you choose to do so. So depending on how much practice you would like in that field, it's available for you. And finally, definitely manage my time better. This is a cautionary tale. I was a little embarrassed when I put this together, but I think it's important because you will graduate general surgery residency. You will feel like you're on the top of the world and that the boards are so far away, but they're not. They're looming in the background in a very busy portion of your life. So I finished my residency June 20th, and I just mentally couldn't even think about studying at that time. So I said July 1st is when I'm going to sit down and study for the written exam. So I studied, took the exam, and then all of a sudden, it's 2 weeks before fellowship starts, anxiety starts kicking in. And then there's this huge adjustment period, which I kind of underestimated starting fellowship. So during that time, I thought I would have my set plan. I know which weekends I was going to study for. I said September 1st was the absolute last date before I would start studying. And embarrassingly, I did not start studying until well into October. I do not recommend this at all. I was probably chewing Tums on a daily basis based on the amount of anxiety I got before the certification, the certifying exam. So I do not recommend it. I think what all the other speakers have said about having a stepwise regimented plan is good, because in this last kind of witching hour before your exam, you're going to be flustered and wanting to study to access things that might not be super high yield, things that you're not uncomfortable with. So in retrospect, I would have just put myself on a very more regimented study plan. So that's the end of my talk. Best of luck to all of you. You all have the knowledge from your clinical training as well as your studying. Just don't do what I do. And I was very lucky. I felt like my residency trained me really well, and studying for the written exam actually helped a lot. But I would not recommend doing what I did. Please study regimented early. The fact that you're in this session right now listening tells me you're not going to repeat my mistake.
Thank you so much, Faven. That was fantastic. Of course, as a CT fellow, you have to throw an ECMO in your talk somewhere. At this time, we can open it up to a Q&A. If anybody has any questions for any of our panelists, Dr. Lau, Dr. Vreeland, Dr. Babu, or myself, Z, Dr. Artiri, would be happy to talk about some of our experiences too as well. If anybody has any questions, please feel free to ask.
I just wanted to ask how many of the panelists actually took one of those courses. I know Dr. Vreeland said that he didn't take it. I was just curious, like anybody else. I took one. Dr. Lau?
I did not.
And Dr. Babu?
I did, but I just used the virtual video library. I didn't do it as a structured 2-week program that they have.
I'm just curious, our most recent fellow actually didn't take one and did fine. I think the key for that is practice, practice, practice.
Yeah, I think the big advantage I found for the Osler course wasn't necessarily the content, but it's just one area that has as many scenarios as you can think of clinically. So to me, it was all about seeing, like, I'm the type of person I can recall a lot better from things I hear and see than I can when I read. So just hearing those scenarios helped me get a really good structure of how to start off any prompts I got.
I also thought it was very helpful because they do offer a practice session. And so you log on to Zoom and they give you 3 or 4 scenarios in a room. And it's just really helpful to kind of simulate that setting to kind of ease some of your anxiety, or I had some anxiety going into it, so that when on the actual test day, then you've already kind of been through it once before. And the content I thought was very good. Let's see, there's a question about, did you get to pick your exact CE date? That's a great question. So they tell you the week that it is, but you don't actually get to pick your date. You get assigned either Monday, Tuesday, Wednesday, Thursday, Friday of that week, and then they don't tell you until, I want to say, a few weeks before. So no, you don't get to pick your date.
You do get to pick the session though, right? Now there's a couple of sessions in terms of the, oh, this is for the C. Okay, never mind. If there's no more questions, I guess we can preclude our webinar for the sake of everybody's time. But I just wanted to say, please stay tuned for our next webinar, which will encompass some oral board scenarios. And I just wanted to thank all our speakers, Dr. Khan, Lau, Vreeland, and Dr. Babu for the amazing talks. And of course, our moderator, Dr. Linda Q. As well as the people behind the scenes, Dr. Zivan Fong, and the person who is very important, who does basically the backbone, Beverly Henry. And also good luck to all of you taking the written boards next week. I know you guys are gonna do great, so thank you.
Thank you so much for being here.
Thank you. Have a great night.
Thanks, y'all. Good luck, everybody.